Okay, Assalamualaikum warahmatullahi wabarakatuh. So our group will be presenting a topic on peripheral vascular disease, on arterial and venous disease. Next. So we'll be covering a case presentation, peripheral venous disease, peripheral artery disease, and also ulcer. Next. So for the first part, case presentation will be presented by me. Next. Will be covered all of these parts: chief complaint, HOPI, physical examination, investigation, and also management. So for the chief complaint, Mr. K, a 68 years old Chinese man, a smoker with underlying diabetes mellitus, hypertension, and dyslipidemia, presented to the suspect with worsening right limb pain, swelling, ulceration for 1 week duration. So he presented with right limb pain with intermittent and throbbing in nature since 3 months ago, and it was worsened 1 week prior to the admission. He also had nocturnal night cramp, usually at rest, described as pulling in nature, with initial pain score of 2/10 and then progressed to 6 to 7/10 for the past 1 week. He also complained that the pain will disturb his sleep, and then and then the pain will relieve by hanging the leg on a pillow. He also described the pain as a tightness of the right limb. And then next is he also complained of a right lower limb swelling. It was sudden and not aggravated by any trauma or insect bites. It was localized at the right lower limb, and it was began from right foot, extend up till the mid shin. And it also associated with pain, with a pain score of 3/10, and the swelling was erythematous. The pain was described as throbbing in nature. And then he developed a ulcer. It was started with a blister at the medial side of the right lower limb. It gradually increased in size and then ruptured on his own on the third day of illness. There's a clear discharge from the ulcer site. There was no blood and pus noticed. For functional status-wise, previously he can ambulate independently. Currently, he need to use a walking stick, and also in the ward, he need to use crutches. And then because of this, his activity cannot do well. He reduce distance of walking, and also he not able to sleep well at night. Next. So since 3 months ago, he also complained of intermittent claudication with sharp cramping in nature, and sometimes resemble muscle cramping. The pain was over his foot and also calf. It was developed after 10 to 15 minutes of walking, and we relieved by resting before he continued walking. The pain was not radiating to elsewhere. He also noticed a dilated vein over bilateral lower limb since 1 year ago. It was painless and does not disturb his daily activities. Otherwise, there was no blackish discoloration of the affected site, no fever, no nausea, dizziness, sweating, shortness of breath, chest pain, palpitation, orthopnea, and also PND. So on further questioning, this is his second episode of similar presentation. His first episode was 11 months ago in August 2022 with formation of ulcer at the medial side of right lower limb that ruptured with clear fluid, and also a non-healed ulcer at the lateral side of the right lower limb. It was treated with antibiotics and done wound dressing. Next. So for the past medical and also surgical history, he was diagnosed with diabetes mellitus, hypertension, dyslipidemia for the past 15 years, and was under follow-up in KK Bukit Sekilau. For diabetes, he was on insulin 2 times per day, and also one type of oral anti-diabetics, and also metformin 1 gram BD. His latest HbA1c was 6.7 in May. For his dyslipidemia, he was given simvastatin, and for his hypertension, he had three types of antihypertensive: perindopril, amlodipine, and also hydrochlorothiazide. He also had history of plating of the right femoral and also left radius in 1985 due to MVA. He also had history of cataract operation in 2015 and also 2016. This is his second hospitalization with current complaints. So for drug history, as I mentioned before, and also he denied history taking of traditional medicine. For family history, he had strong family history of diabetes mellitus and also hypertension. He is second out of three siblings. There was no history of cardiovascular disease or premature death in family. No family history of malignancy. So for social history, he is a smoker with 40 pack years and non-alcoholic. He worked as a sailor. Next. So for physical examination, on general examination, he is a medium built man, alert, conscious, not in pain or respiratory distress. His peripheries were warm and CRT less than 2 seconds. For vital sign, he is blood pressure hypertensive with 150 over 75, heart rate 60 beat per minute, good volume with regular rhythm, non-tachycardic, non-tachypneic, and also for temperature is febrile. And the score during night is 5 to 6 over 10. Next. So for the examination of the right lower limb, so there is ulcer at the medial malleolus, circular in shape, measuring 2 times 2 centimeter. The margin was regular with slow pH. There was a pink and granulation tissue at the base of the ulcer. There was no exposing bone or tendon, no discharge or bleeding. And also there was a blister and swelling of the second two of the right lower limb. There was a hyperpigmentation, lipodermatosclerosis was noted of the right lower limb. There is trophic changes of the right lower limb with loss of hair and also dry skin. There's also atrophic balance over the lateral malleolus measuring 6 times 5 centimeter, indicate a heel ulcer of the previous episode. There's also dilated vein medially and also posteriorly up until mid-thigh. So it was warm in palpation, CRT less than 2 seconds. There's tenderness over the erythematous area. And then he had a limited ankle joint movement and also unable to plantar flex and dorsiflex the foot. So for the pulse, femoral pulse was palpable, popliteal diminished, and then for PTA and DPA was unable to appreciate as swelling and thickening of the skin and tenderness and complaint of tenderness by patient. And next. So for physical examination of the left lower limb, there's a presence of hyperpigmentation and also corona phlebitica. There's a presence of dilated veins up till knee. There was no swelling and also ulceration. There's a CRT less than 2 seconds, no tender. So for the pulse, femoral artery was palpable, popliteal was diminished. For the left lower limb, there was no limited range of movement. So for the special test, tourniquet test revealed incompetence of the saphino-popliteal junction over the right lower limb. And then for Berger test was not done. So for LBSI, right for the right limb, right lower limb, it was 1.16, and for the left, 1.08. Next. So for diagnosis, it was diagnosed as chronic limb ischemia with mixed features ulcer. Next. So for investigation, I divided into bedside, blood test, and also imaging. So for bedside, the capillary blood glucose was done, and it was revealed result of normal around around 5.5 millimole per liter, and then was done ECG with right bundle branch block, and also done ultra-duplex ultrasound, revealed SPJ incompetent, femoral artery highly calcified, and then there's a visualized flow that's seen down to the mid-thigh with a weak flow, and also done venous duplex ultrasound. And then for blood test, uh, the patient was done full blood count, plasma glucose. So for the full blood count, HB was slightly low, was low with a result of 11.6. White blood cell count 12, uh, and then platelet with 197, normal platelet. So for plasma glucose, like it was 5.5. And then for HbA1c was 6.3. It was normal. So for coagulation profile, renal profile, lipid profile, is all are normal. And then for blood culture, at that time it was still pending. And then for imaging, in the ED, there's three imaging was done: X-ray of right foot, AP, and also oblique. X-ray of right ankle, AP, and lateral. X-ray of right tibia, fibula, AP, and lateral. And then ultrasound Doppler of lower limb was done after he was in the ward. The impression was for the right lower limb, there is intraluminal synechia within right mid-femoral, and also popliteal veins, keeping with chronic post-thrombotic changes. There's also varicose veins underneath the ulcer at the medial aspect foot. And then he was planned for diagnostic angiogram for the right lower limb. Next. So management for this patient, he was treated with intravenous unacin 3 gram TDS, and then was managed with analgesic and also pain management. At first, he was given intravenous tramadol 50 gram start in ED, and then continue in the ward. But in ward, he developed worsening night pain of the right lower limb, and then he was referred to APS and given oral PCN 1 gram QID, tap oxycodone IR 5 mg TDS, Cisalabrex, oral Myonal, and also capsule gabapentin to manage his pain. And then he also was given VTE prophylaxis, uh, sub apa Clexane injection, and then every other day dressing on the ulcer. I think that's all from my part.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I will be continuing the presentation today with the next part, which is peripheral artery disease. So in this presentation, we'll divide it into two: the limb ischemia and also aneurysm. Next. So the first one, limb ischemia, it can be divided into acute and chronic limb ischemia based on its duration. So the first one is acute limb ischemia. So by definition, it is inadequate arterial blood supply to a limb where there is sudden decrease in arterial perfusion of the limb. There is a potential threat to the survival of the limb itself, and also it requires urgent evaluation and management. So as the name says, acute, the onset is less than 2 weeks. The common causes of acute limb ischemia includes embolism or thrombosis, peripheral arterial aneurysm or dissection, and also traumatic arterial injury. So the risk factors to develop acute limb ischemia includes gender male, older age like 60 to 70 years old, uh, smoke, smokers, patients with diabetes mellitus, hypertension, dyslipidemia, and also obesity. Next. So the clinical features of acute limb ischemia, you can see the picture at the side. The patient usually comes with pain, paralysis, pulselessness, or if you felt the limb, it is perishingly cold. it looks pale, and also there is paresthesia. So we must ask the detailed history of each symptom, like in the case presentation mentioned before, like for example, pain. Where's the pain? Is it in the upper or lower limb, or is it affecting one or both sides? Which part of the limb? What precipitates or relieve the pain? Extent of changes that it has done to the limb. And then when the symptoms start, is it sudden or gradual onset? Is it getting worsening or better? And then is it worsening during the day or night? And then initiating factors like preceding activity or events, such as, for example, the patient had trauma before he or she developed the pain. And then exacerbating factors like exercise or posture. And then relief factors such as hanging the leg out of the bed, or elevating the leg, or giving analgesic to relieve the pain. And then the nature of the symptom, the severity, the periodicity, is it continuous or intermittent pain? And then the pain side, severity, timing, precipitate onset, radiation, the Socrates, the impact of the symptoms on the patient. For example, it affects the quality of life of the patient from walking, sleeping, and sitting comfortably. And then does it cause disability of the patient? Like if it affects the hand, the patient has impact rate or heavy arm. And then any history of recent trauma to the limb, such as fracture or treatment, dislocation or soft tissue trauma, any like motor vehicle accidents. Okay, next. So like I mentioned before, the clinical features of the acute limb ischemia, uh, it can be easily remembered using the 6P. So the first one is pain, and the next one is paresthesia or numbness of the limb. And then the next P is poikilothermia, where there is perishing feeling of the cold. If you feel the limb of the patient, you can feel that the limb is very, very cold, like you put it directly under aircon. And then paralysis of the limb, whether there is loss of movement. And then the skin looks pale, and there is diminished pulse. So how can, from physical examination, we can also do the ABI or ABSI, ankle brachial index. The normal value is usually 0.9 to 1.3. So if it is greater than 1.4 or lesser than 0.8, so it is abnormal. Next. So for investigation, we should do baseline investigation. Usually, acute limb ischemia patients can need should need surgery. So baseline investigation include like full blood count to exclude any anemia, blood glucose and HbA1c to look for diabetes, and then if the patient have any renal disease, do the renal profile, serum urine and electrolyte, and then do the coagulation profile, and also do ECG, electrocardiography, because the patient might have any heart abnormalities. And then the important one is we should do Doppler ultrasound, like in the case presentation before. And then we can also do CT angiography or MR angiography. So in this slide, you can see the Rutherford classification of acute limb ischemia. It can be categorized into category 1, which the limb is viable. So the prognosis of the limb is it is not immediately threatened. And in physical examination, there is no sensory loss, no muscle weakness, and Doppler signs are good. For category 2, it can be divided into A and B. So for marginally, category 2A, the limb is salvageable if it is treated immediately. For findings, there was minimal sensory loss, and then there is no muscle weakness. The Doppler signs often not hurt in artery and hurt in vein. For 2B, immediately, the the limb is usually manageable but with immediate revascularization. The sensory loss are usually more than toes, more than minimal. And then there is mild to moderate muscle weakness, and Doppler signs are usually inaudible in the artery but audible in the veins. So for stage 3, it is irreversible acute limb ischemia. So it is a major tissue loss or permanent nerve damage. There will be permanent nerve damage. So for findings, we will find profound anesthesia or sensory loss in the limb, And then there will be profound paralysis or muscle weakness. There will be no Doppler signs. Next. So for management of acute limb ischemia, so first of all, we should give systemic heparinization with IV heparin bolus, a high dose, and then manage the patient accordingly, according to the ABC, like give supplemental oxygen if the patient needs, and then give pain management, analgesics, and IV hydration. And if the patient present with other associated conditions like any maybe diabetes or any heart problems, so we can treat that as well. And then for the limb itself, we categorize according to the Rutherford classification I mentioned before. For Rutherford 1, we do imaging like Doppler ultrasound, CT angiography, or the SA is digital subtraction ultrasound angiography. And then we should do revascularization surgery within hours using thrombolysis or thrombectomy or surgical bypass. If there is underlying vascular lesion, we should proceed with endovascular therapy and or surgery. You can see endovascular surgery includes catheter-directed intra-arterial thrombolysis or angioplasty. So if the patient presents with Rutherford 2 classification of acute ischemia, we should do urgent revascularization like thrombectomy or surgical bypass. And then if the patient presents with irreversible or Rutherford 3, usually it is in stage, so we recommend to do amputation. Next. Okay, so that's all for the acute limb ischemia. So we proceed with the next, which is chronic limb ischemia. So by the name itself, chronic is more than 2 weeks duration. Chronic limb ischemia is when there is chronic arterial insufficiency. It is mainly due to atherosclerosis. And the most common symptom is intermittent claudication, as you can see in this patient that Aisha have presented before. So intermittent claudication is the patient has reproducible pain upon exertion, which relieves at rest, and it usually affecting the cough because when, for example, when yeah, next. Okay, so for the clinical features of the limb, it usually have a shiny smooth skin with signs of muscle wasting, and there is presence of ulcer or gangrene with absent or diminished pedal pulses, the foot pulses, and the CRT is more than 2 seconds, and there is positive Burgers test. So Burgers test, how is it done? It is done when the limb is elevated to 30 degrees for 1 minute, and it is positive if the limb goes wide. Okay. So in the second picture from above, you can see that it is positive Burger sign. Next. So this is basically the pathophysiology of the limb ischemia. I think you can read later. Next. So for chronic limb threatening ischemia, it is ischemic pain in the foot where the person is at rest with pain lasting for 2 or more weeks with non-healing wounds or gangrene. That is usually by arterial occlusive disease. It is the end stage of peripheral arterial disease and the final stage of atherosclerosis. So it is associated with a high risk of limb amputation. So the patient usually comes with more than 2 weeks of recurrent foot pain at rest, and they require a regular use of analgesic because of the pain. So the ABI index is usually less or equal to 0.4, and then there is a non-healing wound or gangrene of the foot or the toes. Next. So for investigation, it's similar to the acute limb ischemia. We do the baseline investigation, the laboratory investigation for blood count, lipid profile, renal profile, ECG, and then we do duplex ultrasound and CTA or MRM. So this is the assessment of the risk of amputation using the YFI classification. So for the W is wound, for the I is ischemia, for the FI is the foot infection. For the wound, we classify into 0, 1, 2, 3 based on the presence of wound or ulcer. And then for eye ischemia, we classify according to the ABI index or ankle pressure index or foot pressure index. And then for the foot infection, if there is signs of infection, local or systemic sign of infection. Next. Okay, so for management of chronic limb ischemia, it can be as usually can be divided into conservative or non-surgical and surgical intervention. So for conservative, we should advise the patient to do lifestyle modification like smoking cessation because it is a risk factor for having limb ischemia. Encourage the patient to have healthy diet, less in fat, less in cholesterol, and then do more physical exercise. And then for pharmacological management, we can give antiplatelets such as aspirin, analgesic to control the pain, antibiotics if the patient has infection, and then control the hypertension and the diabetes, and also the hyperlipidemia. For surgical intervention, we can do revascularization surgeries such as angioplasty, surgical bypass, or stenting. And then, if the limb is not salvageable, we can do amputation. Next. So, for the follow-up of the patient, encourage the patient to do rehabilitation. We look for dependency of the revascularization that we have. And then monitor the coronary artery or cerebrovascular disease that the patient have because we don't want any recurrence. And then monitor the other comorbidities that the patient has. Next. So this is the summary of the acute versus chronic limb ischemia. So acute versus chronic is based on the duration, and then acute is sudden disruption in arterial supply. Chronic is chronic disruption in arterial supply. The most common cause for acute ischemia is thrombosis or embolism, and chronic limb ischemia is usually caused by atherosclerosis. For acute limb ischemia is usually you should remember the 6 P's, and for chronic limb ischemia usually comes with intermittent claudication. Okay, I think that's all for my presentation. We'll proceed to the next.
Okay, we continue with the aneurysm. Okay. So aneurysm is defined as a localized area of pathological excessive arterial dilation with at least 50% of increase in the diameter of the vessel of the artery. It is relatively uncommon, where however is found mainly in males over 70 years age. The etiology because erythematous mycotic bacteria is because of a bacteria infection or fungal infection, and it's because of collagen disease such as Maffer disease, and also because of traumatic event. The morphology the morphology of aneurysm because it has two aneurysm and pseudoaneurysm. Aneurysm can be occur in large arteries such as aorta, iliac, femoral, popliteal, subclavian, and the others. So just a morphology of aneurysm. There is two where it is two aneurysm, first aneurysm where the two aneurysm there is a dilation of all three layer of vessels such as intima, media, and retia. However, the first aneurysm is dilation of artery where it's not involve all three layers, where it's because of a collection of blood or hematoma with fibrous covering. After connected with the vessel lumen and blood swell inside the false aneurysm. So aneurysm usually if it is small is usually is asymptomatic, and usually patient is discovered incidentally as a persistent mass uh, in abdomen, groin, or pubic fossa, or because patient have doing any imaging such as abdominal X-ray, CT, or ultrasound scan. However, if it's large enough, it can affect the distant organ, affect the site where it involves, such as in abdomen, it can be present with pain or a tender. And if when it becomes activated, it usually is need a urgent surgery. If we does not organize earlier of aneurysm, usually patient come with a sudden death. And also there is a presented with a leaking or rupture aneurysm, such as ill-defined back or abdominal pain, often stimulating the uterine coli or other abdominal emergency. And also it also can present with acute severe ischemic, usually aneurysm at the popliteal aneurysm or collateral side. Also there is also a complete arterial occlusion, where there is a sudden distal ischemic affecting lower limb due to embolism or thrombus within the aneurysm. And yeah. So abdominal aortic aneurysm, uh, is the most common type of a large vessel aneurysm found in 2% of the population at the autopsy, where the small is about it can describe as like the size like small within a large according to the size. And the risk factor to get abdominal aortic aneurysm, such as hypertension, hyperlipidemia, COPD, family history of uh, type A, where which usually ask if in the family there is a sudden death occur, uh, sudden death occur, and patient if patient have a cerebral vascular disease or history of stroke, social history of smoking. And last common cause of the type A is a collagen vascular disease, such as Marfan, Ehlers-Danlos syndrome, and mycotic aneurysm. Uh, Add on a clinical manifestation of a rupture type A, where it's typically presented with palpable versatile abdominal mass with pain and has a testing collapse of hypotension because of because of the blood loss itself. If it happen to the rupture in the vein cava, there will be last heavy fistula, where its symptoms include the tachycardia, congestive heart failure, leg swelling, abdominal trill, and there is like a missionary type of abdominal void with the failure and peripheral ischemia. If it was ruptured to the fourth portion of the duodenum, patient will be present with symptom of the upper GI bleed and massive hemorrhage. So for investigation, abdominal aortic can be investigated by using ultrasound to look the size itself there, or can do CT scan. Usually it is for the elective operation when it's planned. And the management for the first time management, we must if the patient is unstable, we must resusc and stabilize the patient. Allow pervasive hypertension to facilitate investigation, and blood investigation such as APC, RP, FT, and blood glucose mass. And also vital signs monitoring is important for to look for the BP, change of BP, and any tachycardia or hypercardia. CT scan to plan the site of surgery, and the definitive repair for the aneurysm is open surgery or endovascular aneurysm repair. So indication for type A surgery, the size of aneurysm itself, where it's about 5 to 5.5 cm, and the is expand for the if patient have aneurysm before, the expand 0.5 per year. Present of circular aneurysm, symptomatic such as abdominal pain, back pain, uterine convulsion or embolism, or there is a leaking or rupture aneurysm. Like I said before, there is two types of surgery, which is open abdominal aortic aneurysm and endovascular aneurysm repair. So the principle of is two type aortic and femoral aneurysm, where we use a tube graft or bifurcation graft or synthetic material. And popliteal aneurysm using autogenous surface vein, we use patient surface vein to make a revascularization of the artery. So there is two types. Upon abdominal aneurysm surgery, where is standard approach of midline antiphosphonate insertion, where is usually we give a pre-operative anticoagulation before the surgery. And for the endovascular aneurysm repair, it's a minimally invasive technique using stent graft, where it performed mostly under general anesthesia and can be also local. There's possible complications such as endovascular leak, possibility secondary intervention, and because we use uh, like graft, we must have a lifelong follow up. I think that's all for me.
Okay, we will continue the presentation today with the next topic, which is peripheral venous disease. So in this topic, we have two subtopics, which include varicose vein and also venous thromboembolism. Varicose veins are dilated, tortuous, and prominent superficial veins in the lower limb, as you can see in the picture. And it is common in worldwide, but usually patient is asymptomatic, and only 12% have symptoms or complications. The risk factors for developing varicose vein include being a woman, and because a woman has a high risk of getting varicose vein, about 6 times more than men, and the risk increases with age. And the next risk factor is high BMI, high the height, and also the weight also increase the possibility of getting the varicose vein. The next is pregnancy, and the last one is family history of varicose vein. Next, for the pathophysiology of varicose vein, um, varicose vein is mainly due to the abnormal communication between the deep and superficial venous system. So in the vein, we know that each of vein has a valve which prevent backflow or retrograde flow of the blood. So when these valve fail to function normally, then the blood from the deep venous system can flow back to the superficial venous system, causing congestion and dilated vein. So the most commonly affected site is the saphenofemoral junction, and varicose vein is a slowly developed condition which occurs uh, from 10 to 20 years, and it commonly involves the long saphenous system. For more information, you can further read in the picture provided. Next. Sort of clinical features, the most common complaints for varicose vein include aching legs, usually after standing all day, but the pain or aching pain is relieved with elevation of the affected legs. And that's why it poor cosmetic appearance because the dilated veins is visible, and fear of future leg ulcers, bleeding, and usually bleeding from the varicose vein will be a lot, varicose eczema, ankle edema, and also superficial thrombophlebitis. The signs of varicose vein is tortuous dilated superficial vein, which can be visualized, and for if the varicosity affect the great saphenous vein, we can then the vein at the medial thigh and calf will be dilated. So we can see varicosities of the vein within this area. For short saphenous vein, most common site is the posterolateral calf, and the anterior saphenous vein at the anterolateral thigh and also calf. And saphenavarics is the dilatation of the vein at the saphenofemoral junction in the groin. Next. So for the initial assessment, for the severity, we need to determine the severity of varicose vein. So we need to examine the extent and severity of varicose vein with the patient standing, and if there is any skin changes such as swelling, ulcers, or varicose eczema, if present, it could indicate a post-thrombotic limb, a long or short saphenous system, is We need to know whether the varicosities is from the long or the short saphenous system, and also to examine the distribution of the varicose veins. And this one is CEAP assessment, which I will explain in the following slides, and tourniquet test. Okay, so tourniquet test is a test to locate the site of incompetent valve. So how do we conduct this test? Is simply by ask the patient to lie down and then elevate the affected limb to empty the blood from the distal limb. So and there are four sites to apply the tourniquet in sequence. The firstly, we would apply the tourniquet at the upper thigh, close to the saphenofemoral junction. And then after that, after applying the tourniquet, we ask the patient to stand up, and we see whether there is filling of the distal vein. If the vein still fills with blood after applying the tourniquet, this indicates that the lesion is below the tourniquet level. So if this happen, then we need to apply tourniquet at distal side, which is above the knee or the mid thigh, or at the mid thigh perforator. And we continue to do this test until vein distal to the tourniquet does not fill up. So that indicates the site of the varicosity, or the site of the incompetent valve. Okay, next. So this is the CEAP classification. The purpose of the classification is to categorize chronic venous disorders to facilitate communication, and it is not used as a measure of clinical severity. So in CEAP, we have the four domains. The C is the clinical classification, as you can see in the table provided. E is the etiologic classification, whether it is congenital, primary, secondary, or no venous cause identified. A is anatomic classification, which indicate which veins is affected. Either is superficial, perforator, deep vein, or no venous location identified. And the last one, P, is the pathophysiology, whether there is presence of obstruction, reflux, of both, or no venous pathophysiology identified. Next slide. So the investigation for varicose vein, the gold standard is the duplex ultrasound. The aim of duplex ultrasound is to assess the presence of reflux in the deep and superficial venous system, the exact distribution and extent of reflux in the superficial venous system, presence of obstruction in the deep venous system, stability of the incompetent superficial vein for different treatment available, and presence of thrombosis within the superficial vein. Um, if uh, if other investigation needed to be done, then we can include MR venography, which use magnetic resonance technology and IV contrast dye to visualize the vein. Contrast venography, the use of X-ray and contrast to visualize the blood flow in the vein, and also intravenous ultrasound. Okay, so the first picture is the ultrasound finding uh, of the of three vessels in the thigh, which is the saphenofemoral junction, femoral vein, and also femoral artery, which also known as the Mickey Mouse side. And the right side is a picture of MR venogram. Next. So the management of varicose vein. If patient does not have or does not develop any complication, usually we just manage conservatively, such as elevate the legs or wear supporting elastic stockings when standing. However, if patient is indicated for surgery, for example, patient has aching legs after standing and relieve elevation, or when in bed at night, patient have hemorrhage, superficial thrombophlebitis, or venous skin changes, and there are few surgical options that can be done, which include the high saphenous ligation, which usually coupled with long saphenous strip. So another one is a version of varicosities, also known as the phlebectomy. So, in high saphenous ligation, the surgeon will ligate the great saphenous vein, and also the tributaries, and after that, will the surgeon will strip away the great saphenous vein, so it remove the vein totally. And the phlebectomy, next picture. And the phlebotomy is, as you can see in the picture, a small incision is made on the skin, and then the varicose vein, very superficial varicose vein, is removed uh, throughout the skin, so blood will not flow again to this vein as it already removed, and only the viable vein is preserved. Uh, Next. So other non-surgical option for varicose vein include endovenous treatment. The function is to ablate the incompetent vein. So there are three modalities, which is foam sclerotherapy, laser ablation, and also radiofrequency ablation. In foam sclerotherapy, sclerosant substance is injected into the varicose vein, and then this sclerosant substance will induce closure of the varicose vein, so blood will not be able to flow through this defective vein. And as you can see in the picture, and for laser ablation and radio frequency ablation, these two methods um, produce heat, which function the same, which able to induce the closure of the varicose vein. So So the principle of treatment in endovenous therapy is to ablate the vein, or to close or seal off the vein totally, so that blood will not be able to flow. So there will be no dilatation of the vein, so it will not become visible to the skin anymore. Okay, I think that is all for varicose vein.
So we'll continue with the next part, venous thromboembolism. So, venous thromboembolism is the third most common cardiovascular disease after myocardial infarction and stroke. It is common. The rate is about 100 per 100,000 population per year, and 70% of them are hospital acquired. And the most common presentation of venous thromboembolism are deep vein thrombosis and pulmonary embolism. Next. The pathogenesis of venous thromboembolism are described by Virchow's triad, which are venous stasis, vascular endothelial injury, and also hypercoagulability. So, many patients with VTE fulfill most or all of the Virchow triad. And the risk factors that will be explained later for VTE influence at least one of the three mechanisms. So, generally, when there is a venous stasis or following a vessel wall injury, the venous thrombi will occur, usually in venous valve pockets, and this will obstruct the venous outflow, cause inflammation of the vein wall, inflammation of the surrounding tissue, and it may embolize to the pulmonary circulation, and this cause the symptoms that will also be described later. Next. So these are the long pathogenesis of the deep vein thrombosis. You can see the blue ones at the outer parts. Those are the risk factors, and it will contribute to the three mechanisms, to the three virtual triad. For example, malignancy, it will cause abnormal release of coagulation promoting cytokines. It will lead to hypercoagulable state, platelet activation, and also inherited disorders such as factor 5 laden, factor 2 mutation, uh, and also pregnancy or OCP, also trauma or surgery. This will contribute to hypercoagulable state. For vessel injury, hypertension, bacteria, and artificial valve will lead to vessel injury. Um, while in obesity, the fat contains more aromatics, so it converts more androgen to estrogens. Later on, yes, leads to hypercoagulability as well, but also leads to venous stasis. And the sedentary lifestyle or the poor venous return also leads to venous stasis. While for usually seen in the hospital, the immobilization, bed rest, it will lead to reduced muscle motion and reduced venous blood flow, um, cause venous stasis. And these three mechanisms, the Virchow striate will cause clot formation, usually in the leg veins. Why leg veins? Because the deep, large veins in the leg allow for blood pooling. So it contributes to stasis and hypercoagulability, while venous return from legs often against gravity, and valves in the leg veins are prone to backflow. And the complications of this, if the destruction of vein valve, if the clot destruct the vein valve, it will cause venous insufficiency, and if the clot embolize to the lung, it will cause thromboembolism and pulmonary embolism. Next. So, pulmonary embolism, as I said, the virtuous triad contribute to DVT, and if the clot dislodge into the pulmonary artery, it will cause pulmonary embolism. Yeah, this is just the same, and it will cause symptoms later. Next. So the clinical features, the symptoms, or the physical examination that we can find in the DVT patient. Patient will complain of pain in the calf or leg, and the swelling of leg, usually unilateral, are more suggestive. And these symptoms are sudden onset and severe enough to cause difficulty to walk. And upon examination, we can find the involved leg are warm to touch. The muscle that contain the thrombus vein are hard and stiff. We may find dilated superficial veins. And the two terms that we may need to remember in DVT are phlegmasia alba dolens, the above picture, which is pale, large, and swollen limbs, and phlegmasia cerulea dolens, the blue legs, when it occur when almost all main outflow of the veins are blocked. And worse, it can cause gangrene. Such as in the lower picture, you can see in the toes. While for pulmonary embolism, patient will complain acute onset of shortness of breath. We can also find tachycardic, pleuritic chest pain, cough, and hemoptysis if the pulmonary embolism involves the arteries, the vessels near the pleura. In massive PE, patient may present with syncope, and we may also hear loud P2 in heart sounds if there is pulmonary hypertension. Next. So the algorithm for DVT diagnosis, we apply the DVT well score features that such as active cancer, paralysis, recently bedridden for more than 3 days, or major surgery within 4 weeks, localized tenderness, entire leg swollen, calf swelling, pitting edema, collateral superficial veins, previously documented DVT or alternative diagnosis. So add up these points. If the points are 2 or more, then DVT is likely. If less than that, then DVT is unlikely. So what to do if DVT is likely? So we do the next investigation, which is CUS compression ultrasound. If the finding is positive, then the diagnosis of DVT is established. If negative, then we repeat the ultrasound in 1 week. Yeah. Next. This is for algorithm for PE diagnosis. We also apply well score. The features are clinical signs and symptoms of DVT. Alternative diagnosis is less likely than PE. Heart rate greater than 100 beats. Mobilization, previous DVT or PE, hemoptysis or score is more than 4, then PE is likely. So if PE is likely, we proceed with a CT pulmonary angiogram. If positive, then the diagnosis of PE is established. If negative, then we repeat the ultrasound. Next. So these are the investigations I mentioned before. The compression ultrasound for DVT. Um, in the picture, we can see usually vein is compressed in normal veins, but in the presence of thrombus in the vein does not compress. In CT pulmonary angiography, we will find intraluminal defect of the pulmonary artery. Um, for D-dimer test, it is used to exclude DVT and PE. So D-dimer is a degradation product of cross-linked fibrin. It is highly sensitive for DVT. However, it is not specific. So it is used in its negative predictive value. What I mean by that is if the value is less than 500, then it is useful to exclude DVT and also PE. Next. For management of VTE, first is systemic anticoagulant. We can either use low molecular weight heparins, which is usually used, Clexane, or tinzaparin, or we can use fondaparinux, and these two used for 5 days or until the INR is the value is 2 or more for 2 consecutive days. Or we can use a rivaroxaban for 3 weeks, followed by 20 mg daily. In provoked VTE, in the case of provoked VTE, where the cause of the clot uh, is identified, so we use warfarin once daily within 24 hours and continue for 3 months. While for severe renal impairment patient, we give IV unfractionated heparin with dose adjustment based on APTT. Next. Thrombolytic therapy may be offered in a few situations, such as in life-threatening massive PE and also in venous gangrene. So in life-threatening massive PE, we offer thrombolytic therapy, and we may also consider pulmonary embolectomy or percutaneous catheter thrombosis fragmentation. While in venous gangrene, we offer thrombolytic therapy, and we may also consider venous thrombectomy or catheter-directed thrombolysis. And the agent for thrombolytic therapy is the tissue plasminogen activator, 100 mg IV over 2 hours, followed by therapeutic heparin infusion, or streptokinase 250,000 international unit IV bolus, followed by 100,000 IU over 24 hours. Next. Mm, um, other option for management is the vena cava filter, and the indications for this filter is when patient is contraindicated to anticoagulants, or where there is large free floating iliocaval thrombus. So the filter is placed via percutaneous route to trap the veins towards the pulmonary arteries, as in the picture. Next. Mm, for prophylaxis of VTE, it is divided by two, mechanical and pharmacological, such as graded elastic compression stockings, intermittent pneumatic compression, venous foot pump. While for pharmacological, we may offer low molecular weight heparin or fondaparinux or unfractionated heparin, or newer oral anticoagulants such as dabigatran, rivaroxaban, and apixaban. So I think that's all for venous thromboembolism.
Okay, so moving on to the last part about ulcers. Okay, next slide. So we are going to see the difference between venous ulcer, arterial ulcer, and also neuropathic ulcer. So for venous, usually patient will come with a history of varicose vein, history of deep vein thrombosis, patient who are obese or currently pregnant. And then for arterial, patient usually come with history of diabetes, hypertension, atherosclerosis, and intermittent claudication. And as for neuropathic ulcer, as we all know, diabetes, and the patient might have a history of recent trauma or repetitive pressure. And then for the pain, arterial ulcers are the most severe pain, followed by venous ulcer, mild to moderate pain, and neuropathic ulcer are the painless one. And then for the side, for venous ulcer, usually it has a gaiter distribution, as you can see in the picture. So that is the gaiter area. And also at the malleola, with the medial malleolus are more common compared to lateral. And then for arterial, usually at the pressure side and also at the distal points, which are the toes. And also for neuropathic ulcers at the pressure side. And then about the surrounding tissues, usually for the venous ulcer, we can see a varicosities surrounding the ulcers, peripheral edema, status dermatitis, and the pulse are usually still present. And for arterial ulcers, patient has a shiny skin with a reduced hair, and then the skin are cold and pallor, weak to no pulse, and delayed CRT. And then for neuropathic ulcers, patient has foot deformities, dry and shiny skin with decreased sensation. And then next slide. So about the characteristic of the ulcers, as you can see in the pictures. So the venous ulcer are usually irregular, shallow and flat margin. It has slough and also a granulation tissue. For arterial ulcers, it is usually a punch out and deep. There is no granulation tissue, and we can see the presence of necrotic tissues as in the picture. And then for neuropathic ulcer, usually it has a regular outline. It is a punch out, deep and surrounded by callus. So what are the treatments? For venous ulcer, it has conservative and surgical treatment. For conservative, you can do a compression therapy or leg elevation. And then for arterial ulcers, so we aim for revascularization, lifestyle modification, like for example, we advise regarding the diet, regarding the physical activities, and also we can give antiplatelet medications. For neuropathic ulcers, like we all know, that for example, in patient with diabetic neuropathy, so we will advise regarding food care management. We do wound debridement and do lifestyle modifications like similarly diet and also physical activities. So next slide. So these are a very nice diagram to sort of differentiate between the arterial, venous and neuropathic ulcers. So we look at the picture above. So it is about how the ulcers happen. Like for example, in arterial, because of impaired arterial blood flow; in venous, because of chronic venous insufficiency; and in neuropathy, because of diabetic neuropathy. And then it also has the pictures of how the ulcers look like. And if you look at the arrow down below, is about the pain scale of each of the ulcers, with arterial being the most painful, the very painful ones, and neuropathic is the painless one. Next slide. So these are our references. Next slide. Okay, I guess that's all for our presentation. If you have any question, you can ask later on during the Q&A session. Thank you.